That is thanks to all of you for getting the word out. Thank you so much. Yay. We also want to thank our sponsors who help us keep these events free and with food so that everyone in a company can attend, not just the C-levels getting to go to big conferences. This is the same kind of quality education that you would get there. And so we appreciate our panelists coming out tonight, and we appreciate our sponsors. So here's just a quick agenda. We're going to try to keep announcements to a minimum because we are jam-packed, and we have some of the rock stars of the industry here tonight, which is great. And we've been requested by Pillsbury to empty the premises by 9 p.m., so please try to be mindful of that. And if we come and try to herd you out, don't worry. Okay, our event schedule next month is going to be at Stanford Medical School, Exact Vocation TBD. No meeting in November. We're going to have our Mingle Jingle in December, and we are still looking for a location for the 1.5-day conference in January. So if any of you have space at your companies and would like to host a group of awesome people for a day and a half, please call me maybe. That would be great. And announcements. We have a couple folks that wanted to make announcements. Please speak up.
I just wanted to
Louis,
say,
go for it.
yeah, I just wanted to say I've been uploading. I have most of the videos ready to upload. I've uploaded a couple for the past events this year. So it's basically the channel's called on YouTube. It's called Health Tech Forum, all one word.
Health Tech Forum, all one word
Yeah.
for the YouTube channel.
Yeah. So it should come up if you do that search. So enjoy. It's not Steven Spielberg quality, but you know. And
Greatest mix medley.
yeah. So, but it does the job. So check it out.
Excellent. Okay, anyone else in the back?
I was just going to say, if you can post the link to those videos on the meetup site, that would be much easier to find them.
Yep, can do, thanks.
What was that hashtag?
Oh, SBHTF. We get why personalized medicine is a big deal. This is one of my favorite statistics, and it's courtesy of Steve Burrill and the Personalized Medicine Coalition. And it's funny, personalized medicine was on the cover of the New York Times yesterday, and my finance guy, non-scientist husband, comes running to me, you know, really excited. Hey, honey, personalized medicine is on the cover. It must be a really big thing now. Yeah, honey, it's kind of a big deal. So I think one of the things I want to be mindful of tonight in the panels and presentations, we all get why this is so important. We understand that there are significant regulatory, reimbursement, and clinical adoption hurdles. But one of the biggest challenges that the industry is going to have is actually educating people who don't really understand it and why it's so important and why we need to keep pushing. So please be mindful of that, and let's all try to help advocate for this very exciting industry. And with that, I'll hand it over to Jim Vaughn. We are not going to introduce people as they come up for their presentations. All of you should have bios on your chairs. If you didn't get one, just raise your hand and we'll have somebody get to you in the back.
Okay.
Thank you so much.
Great. Thank you, Rhonda. You know, I'm going to tend to be a loud speaker, so let me know if you can hear me in the back and whether or not I need to use the mic. Are you okay? Can you hear okay? Perfect. Well, let me just do a quick opening and a quick thank you for coming this evening and getting a chance to have a discussion with myself and, of course, the other panel members. I look forward to any open Q&A that you guys might have. I work with Genomic Health. We're headquartered in Redwood City, and we're, I guess we've been in this space since initially the company starting back in 2000 and really launching our first product in 2004 in breast cancer. So what I hope to do tonight is just share with you a couple of slides of kind of where we are currently in the space, what we see coming in the future for the upcoming years, and where our focus is from both the research area of the business as well as where we are going to move commercially in terms of our business model. So with that said, as I get these slides to go, we always have a safe harbor statement, of course, highlighting the fact that what we're going to be discussing and sharing is confidential, but also open to comment. So anyway, not unlike the first slide Rhonda mentioned or showed, it's amazing what's happening in this space. And with our focus in the cancer market, there's a huge opportunity both in the US and ex-US, with over 570,000 patients, who are going to die from their disease. But what's amazing, at least in the cancer space also, is that we have over $60 billion which are being spent on cancer therapies with an average efficacy of about 25% response, which is amazing, the number of people who are getting treatments who clearly don't benefit in the majority of cases, but of course with it being such an emotionally challenging disease as well as a critical disease with such an important outcome, that people really want to know and understand exactly what kind of treatment will work best for them. And so therefore the level of evidence you're going to have to do to be able to convince someone of looking at alternatives to a traditional measure of treatment is really quite high. And the data-driven medical oncology audience is really witness to that. And so I think it's really driven our approach both from a scientific perspective, clinical perspective, continued work on the data side, but then also on the patient side to help really educate patients about their own disease and a little bit more about what's happening and the kinds of questions that they can ask themselves, as well as challenge their caregivers. Our initial product was really focused in breast cancer, and we've continued to build that out with various indications or various uses within the breast cancer arena. And at least in our early node-negative business, over 100,000 patients are diagnosed, of which the majority receive chemotherapy. And when we started this back in 2004, something like over 80% of patients received chemotherapy. And so we are making a real impact over the course of the last several years in terms of reducing and really tailoring medications or really treatment choices, if we would, for patients. The amazing thing is that just about 4% of patients really benefit in that area of node-negative disease with chemotherapy. So even though Genomic Health, I think, has made an incredible impact, particularly in breast cancer, we still have a huge amount of room to grow, and we have new products that can still make things even better than what we have today. So even though we have made a huge step forward, we also see that there's great opportunity, and so thus you'll see a little bit more about our continued effort and research associated with next generation type of products. And I think the thing that I love most about working with the folks at Genomic Health is not only the scientific rigor, but also the focus on patient and the focus on what we can do to really help those patients better understand what treatment works best for them. And so I think keeping that focus both in our company and throughout our various work is really pivotal to our efforts and our success. As we look at this revolution, I should say, in cancer care, as I mentioned, you're probably familiar with what we've done in terms of invasive breast cancer and the initial launch there, with continued studies showing predicted benefit beyond just the prognostic benefit in breast cancer. Also recently, and just in the past year, launching DCIS, ductal carcinoma in situ for breast cancer, that question being more focused on radiation benefit and whether or not patients are really going to get any advanced or any beneficial outcomes and treatments associated with that. In addition to that, of course, we've launched also in colon cancer stage 2, and then just recently in June of this year we launched stage 3 colon cancer as well. So we continue to do further work and research in that arena. For those of you that might be following our efforts in the area of prostate cancer, we did just announce a few weeks ago positive data associated with our first validation study in prostate cancer. And so that data is going to be shared early in 2013 at a research meeting. So you'll be seeing and hearing more about what we're doing in the area of prostate cancer as well. Just a couple quick highlights to tell you where we are as a company. We've really expanded our efforts on the international side. We've had great success, I think, in the US on the breast cancer arena. And now with the launching of products in colon and next year into prostate, we've also been moving into the major markets in Europe, in Canada, Latin America. And we've done this in a variety of ways, both with partners, working with venture groups to make the product available and provide access for patients, but then also through the our own efforts and our own hiring out and building out of our own commercial organization into major markets in which we're working with the UK, for example, to gain support from NICE in France, Germany, and Italy and Spain. So you continue to see, if you track our business, expanding growth, if you would, in those markets outside the US. If you look at our total revenue as a business, unlike I think for myself and others who've often worked in pharma, when you launch a product and you've had such high penetration rates, you often have these billion-dollar type products. And yet in the diagnostic space, I think we've done a really tremendous job in terms of making, personalized medicine come to life for invasive breast cancer patients. And yet this year, I think we've done quite well, and we continue to grow our business. And at this point, we're going to be close to $250 million in revenue in 2012. So you can see that continued growth over the last handful of years. And you can see also the various product makeup in terms of what portions are coming out of breast as well as our colon business. Quite frankly, the vast majority of our efforts over the handful of years we've been in business have really been focused on taking those profits or those revenues and putting them back into research and putting them back into new technologies and additional clinical work. And it was only in 2010 that we began to show some profitability. And you can see even now with our continued growth, we see this space that yes, we're profitable, we're self-sustaining, but at the same time, we continue to see such opportunities in various cancer tumor types, in addition to new technologies like next generation sequencing, to be able to even improve upon what we are already offering our patients and clinicians, that we can't help but continue to invest in what we see as a big opportunity. And I think the financial markets have seen that, and they're happy to see us cash flow positive, yet at the same time, they've been supportive of our investment back into the business and into the pipeline. With regards to our breast cancer product, even though we're over 60% penetrated in the US in terms of newly diagnosed patients who have invasive breast cancer, we still see quite a bit of growth opportunity, particularly within certain states. You can see this below, that California, as progressive as we are in so many ways, is not necessarily the most highly penetrated markets. And so you'll see that in the Northeast, the Upper Midwest, and the Southwest tend to be some of our more highly concentrated areas. You might be familiar with some of the research we've also done on the national level with the National Cancer Institute, in which we've kicked off, a couple of pivotal trials. The first really in that of node-negative invasive breast cancer with TAILORx, and that trial was over 11,000 patients. And that trial was completed in 2010, and we're expecting to see the outcomes from that data as early as 2015. So it's going to be it's the largest breast cancer study ever done and completed, and it's just going to be an incredible amount of data. And one of the key issues, or one of the key benefits that the NCI had, was when they kicked off this study, is they allowed up to 6 different chemotherapy regimens to be used in those patients who had a higher recurrence score, and they've collected all the blocks. So they actually are holding all the tumor tissue blocks so that they'll have outcomes associated with the individual treatments, and people will be able to, again, continue to look at new and better approaches to personalized medicine using the cancer tissue that are in these blocks. They kicked off in 2011 a node-positive study in breast cancer. Again, a very large study, again, utilizing Oncotype DX with over 9,000 patients. And so that is up and running in the majority of our SWOG studies, and it's also included in a couple countries outside the US as well. So we look forward to getting some results there in probably a handful of years after that of the TAILORx study. The DCIS score is a new product that was kicked off at the first of this year, and again, it's focused on really a question of radiation benefit and or treatment. So while our first validation study is out there, we're going to continue to do further studies with groups in various countries as well as in the US to provide more and more information and data around radiation and the potential benefit in saving that for women who otherwise are going to be treated, 5 days a week for a cycle of 6 cycles and have all kinds of, post-treatment burns and even physical movement limitations, that if they don't benefit from it, we can certainly save them that sort of pain and that sort of energy. With just a couple minutes left in highlighting this, I did want to touch base on our prostate cancer efforts and what we see there. And in the prostate cancer market, over 250,000 men are diagnosed every year, and yet the vast majority of it, even through normal pathology, is recognized as being relatively low risk. But people don't know, whether they're the one who has an aggressive prostate cancer that can prevent them from, impact their life and impact their survival. And so what we see is we see a vast majority of people taking on some very aggressive surgeries. And those surgeries result in not only incontinence, but impotency, and for what turns out to be about a 3% risk of progression of death or disease. So the question is how can we better identify through core needle biopsy whether or not that's really a naughty or nice kind of prostate cancer, to be able to help men make better choices around their clinical treatment along with their physicians or their surgeons. So the key question being really is, do I have clinically significant disease? And so one of the hurdles we're seeing is that just the education level associated with it, and the willingness for men to even ask the question and not just immediately want to take action and move forward with surgery. So again, it'll be a new market for us, and focusing on the urologist instead of the medical oncologist with the prostate cancer, but nonetheless it's going to be an exciting and new area for us in 2013. When we take a look at the worldwide opportunity for the markets that we're focused in breast cancer, colon, and prostate, we see in excess of a $3 billion opportunity, and it's really a function of getting the education out there along with making the service and the process readily available for access for those patients and those payers in order to make it available. I mentioned earlier about next generation sequencing. This is a new scientific platform that we're involved in, and really it's been amazing, I think, how this field has moved in terms of being able to identify more and more human genome sequencing in smaller and smaller amounts of tissue. And so what we see is a challenge is really the bioinformatics side of combining what we can learn from the molecular biology through these new platforms and translate it into clinical outcomes. Because while there's incredible kinds of cancer panels that are coming out from a lot of companies and with great research, we need to tie them to an actual outcome for people to have the confidence to either accept a change in therapy from what is standard, or to consider not having additional therapy based upon the genomic information we have. So again, I think it's, as you know, a very complicated arena, but one in which I think that the reward for patients and for physicians is very much real. So this just highlights, I think, our 2012 milestones, focusing on both strengthening our financial position so that we can and continue to sustain ourselves as an independent company, invest in global commercial capability. We're seeing continued investment ex-US in terms of both clinical research, decision impact studies to help highlight and show the benefit of these types of opportunities, as well as what we're seeing in the third area, which is our continued research into development and platform technologies. So with that, I'm going to end it and hand it over to the next speaker.
Okay, I've been talking too much all day, so I can't possibly match Jim's voice, so I'm going to go ahead and use the microphone. Okay. Do we have...
Yes.
On the top right, if you hit that exit mic, get ready to
Okay.
There we go. Not only does he do genomics and oncology, but also that's impressive. Okay, you can tell I'm a total Apple person now. I can't even find it. Thank you. Right, here it is, not on the left side. Thank you very much. Thanks, Jim. You know, having had a mother with breast cancer and a father who had prostate cancer, I'm always struck by the work that you folks are doing at Genomic Health, and anything that can be provided to help patients make better decisions about treatments when the number of treatment options is so overwhelming at a time that you're diagnosed with cancer. It's really good work that you folks are doing, so thank you. I think you'll hear some interesting parallels between what Jim talked about and what I'm going to talk about in a different therapeutic area. Sorry, that wasn't because of my parents. I'm for some reason. Okay, focus on the left eye. I'm going to focus on a different therapeutic area, and that is coronary artery disease. And I think you're going to find some interesting parallels in terms of not only the benefits of personalized medicine, but also the need for greater efficiency of care. And so I'm going to talk a little bit about our test, CORIS-CAD, which is the only blood test that's currently available that can safely and quickly identify patients who are unlikely to have obstructive coronary artery disease. So essentially what CORIS-CAD is a rule-out test. It's really designed to rule patients out of unnecessary cardiac workups, which take time, have safety implications, and are certainly quite costly. The patients that we're talking about here are not the patients who are going into the emergency department with crushing chest pain and saying, I think I'm having a heart attack. These are symptomatic patients, but they're stable symptomatic patients, and they're usually showing up in the primary care physician's office. And just a quick primer on coronary artery disease. Essentially, it's an obstruction in the coronary arteries, which are those that are carrying blood to the heart. So those are important. And so as you would expect, physicians work carefully to make sure that they're working patients up quickly if they are folks that they think might be suffering from coronary artery disease. So what happens today? Well, generally what will happen is a patient will go into the primary care physician's office. To give you an idea, the patients that we're talking about go in and see a physician 10,000 times every day. So there are an awful lot of patients. And that will connect to, when I give you an idea of some dollars, some of the overutilization of some of the diagnostic tests that goes on in this therapeutic area. So a patient will go into the primary care physician. The physician will generally work that patient up, try to understand what other clinical factors are going on to determine, is it likely coronary artery disease, or gastrointestinal, or musculoskeletal, or anxiety, or what have you. The primary care physician might also do some early non-invasive tests in his or her office, an exercise treadmill test or a stress test. Those tests are not terribly helpful, however, at determining whether someone does or does not have coronary artery disease. And so more often than not, those patients will then be referred over to the cardiologist. And one of the first treatments that a cardiologist will do is what's called an MPI, or myocardial perfusion imaging, also known as a nuclear stress test. And essentially, this is radiation that's used to actually take a look at the coronary arteries and see how is blood flowing. Are we seeing an obstruction? If the MPI is positive or if it's indeterminate, generally patients will then be sent on to a coronary angiography. And this is really considered the gold standard test in determining whether somebody has coronary artery disease or not. And essentially a catheter is put into the coronary arteries to actually take a look at the plaque buildup and determine whether there is an obstruction or not. And in the case that there is, that's when usually a stent will be placed to essentially prop open that coronary artery. So the whole angiography space got some press about a month and a half ago now, I guess, when there was a New York Times piece that was published about an investigation in an HCA hospital, and found that there were a number of these angiography procedures that were being done with no apparent clinical rationale for them. These are expensive procedures. Angiography generally will run at least $10,000, and so certainly there's been a little bit of concern about is this an effort really to try to help diagnose patients, or is it really about driving revenue from a cardiology standpoint? Yes? Yeah, so the process is to go in with the probe. If they find that there's a blockage, that's when they will place us in. So between these two procedures, in the U.S. alone, on an annual basis, you're looking at $5 billion spent here. So there's a lot of money spent, and as I'm going to take you through in a few minutes, there is more money being spent on these procedures than really need to be. So I think this is some really interesting data that was published in the New England Journal a couple of years ago. And it took a look at nearly 400,000 patients who went in for an elective angiography. And it found that of those 400,000 patients, only 38% of patients actually had obstructive coronary artery disease. So 62% of patients are undergoing this invasive procedure, invasive, expensive, time-consuming procedure, and they didn't have coronary artery disease. And I think what's perhaps more concerning is that 84% of these patients had at least one non-invasive diagnostic test done previously. And so what that demonstrates is that these earlier non-invasive tests are not really doing the job that they are trying to of identifying, yes, this is a patient likely with coronary artery disease, or no, it's not. So the MPI, or that nuclear stress test that I talked about, as I mentioned, is associated with radiation to take a look at the blood flow. So these are done on the order of about 10 million per year, so they are a very frequent procedure. But there was a study published a couple years ago in JAMA that took a look at the aggregate radiation exposure from all different types of medical imaging. And what it found were two real eye-openers, I would say. One is that over a 20-year period, 40% of the patients that were undergoing an MPI were undergoing more than one MPI over the course of 20 years. And so this is the proverbial, to get one test is not to get one, it's often to get multiple. And it took a look at that subset of patients who were getting multiple MPIs and found that the cumulative effective radiation dose was greater than those who survived the Japanese atomic bomb. So we are not talking about a benign procedure by any means. Now this is over a 20-year period, to be clear. So I'm not telling you that if you go in for a single MPI, you're going to get more radiation than you would at Hiroshima. That's not my point. But what I am saying is that because these procedures are not infrequently done year over year in patients, the incremental radiation exposure is really something that folks need to pay attention to. And as a woman, I tend to put sort of radiation in the scheme of, well, how does that relate to a mammogram? That's something I know I got to sign up for, and it's got some level of radiation. I know I have to do that every year. So how does an MPI compare? And so a single MPI has equivalent radiation to 39 nanograms. So these can be very helpful procedures, full stop. So let me be clear. However, they are being done more frequently than they need to be done, and they are by no means benign procedures. So that's a bit about the safety implications of MPI, but I think then you also have to think about, well, if they are really effective, then we might be willing to trade off some of the safety. This is some data that was pulled from the PREDICT trial, which was the first trial in which we used our CORUS CAD test. And the subset here are patients who had obstructive coronary artery disease. So they went all the way to angiography and were found that, in fact, they did have obstructive coronary artery disease. Women are a particularly challenging subset of patients to diagnose with coronary artery disease. They're challenging particularly because the symptoms in women look quite different than they do in men. Men often have sort of what's referred to as the Hollywood heart attack, that sort of crushing chest pain and shortness of breath, the symptoms that you generally hear about pretty frequently. Women's symptoms are much more diffuse, and as a mom, I can say, I suffer from many of those on a daily basis. There are things like fatigue and heartburn and gastrointestinal issues and headaches. And you go, okay, really? Could that be coronary artery disease? So it's really difficult to tease out what in fact are symptoms of coronary artery disease and not symptoms of, I ate something really bad the other night, or I'm working too hard. So that's sort of the backdrop, that women are difficult to diagnose with coronary artery disease anyway. And when you take a look at the utility of the current approaches that diagnose coronary artery disease, you can find that they are doing an even worse job in women than they are in men. So again, this is the subset of patients who had obstructive coronary artery disease, and you can see in the red bars only 20% of women who had coronary artery disease had a positive MPI. At least as concerning, though, is that 25% of them who had coronary artery disease had a negative MPI. So these tests aren't doing a terribly good job of really determining you should go through the cardiac workup or you shouldn't go through the cardiac workup. It's really a bit of a toss-up. So that's the efficacy side of things. So what about the economics? So as I mentioned, we've got about 10,000 patients per day who are going to their physicians with symptoms that are potentially those of coronary artery disease. They are potentially something else, but they look like they could be coronary artery disease. Chest pain is the chief complaint in 1 to 2% of annual office visits in this country. But only 10% of folks are ultimately diagnosed with coronary artery disease. So there are a lot of people coming in with symptoms that look like they might be coronary artery disease, but in fact are not. Non-invasive testing is costing about $3 billion per year in stable symptomatic patients, and then another $2 billion per year is spent on invasive angiography. Okay. Yes?
Is the $2 billion extra that's spent on non-invasive, even when it's like gone negative, is that because there's such a low or such a high false negative rate?
Is the $2 billion partially because...
Because there's such a high false negative rate that they realize that the earlier testing might not be sufficient, so they don't want to totally rule it out yet?
Well, so the $2 billion is total. So that includes the folks who ultimately have coronary artery disease and those who do not. Now, again, you've got, based on the data from the New England Journal, you've got more than half of patients who are going in for those procedures who don't really need them. So, does that answer your question? Okay, so what's an alternative approach? So the Cora CAD gene expression test has been available for about 3 years now. We've run about 30,000 of these patients, of these tests. It's the first gene expression test to identify patients who can safely be identified to be unlikely to have coronary artery disease. So again, the value of the test is really in ruling patients out of unnecessary cardiology workups. I mentioned that women are notoriously difficult to identify with coronary artery disease, and Cora CAD is gender specific. So it's got particular value in the female patient population. This can be done easily in the primary care physician's office. It's essentially a blood draw, so any office that can draw and ship blood can use the test. They send it to us in Palo Alto. We send them back within 72 hours a score. And the score is 1 to 40. And you can see a visual right down in the lower right-hand side of the screen. Essentially, a score of 15 or less means the patient is unlikely to have coronary artery disease. Has less than a 20% chance of having coronary artery disease. In the case of a patient who's got a score of somewhere between 16 and 40, generally they will be referred on to the cardiologist for further diagnostic workup. What we've seen from our 30,000 or so tests is that about 48% of patients have a score of 15 or less. So we're taking nearly 50% of patients out of unnecessary cardiac workups. The real value, as I mentioned, is in the rule-out capability of the test. And so that's demonstrated by this really high negative predictive value of 96% that was demonstrated in our second trial, the COMPASS trial. So what we know from clinicians is that with that level negative predictive value, they feel confident that when they get a score, that that score is in fact representative of what's going on within the patients. So that's a little bit about different disease states, similar issues in terms of need for greater efficiency, but value of personalized medicine. I'm certainly happy to take any additional questions as we go to the panel discussion.
Question.
Yeah.
How much does the test cost?
It's $1,195, and we just last month received Medicare coverage, so now we're in the process of then going out to the commercial payers who, as you would expect, value the impact of Medicare coverage pretty significantly. Yes.
Question, is there a time limit for the rule-out period? So if you do a test today and it rules you out, does that mean that rule-out is effective for 3 months, 6 months, a year?
Yeah, so it's a good question that we are grappling with currently. So in case folks didn't hear the question, how long can you be sure that the score is accurate? What we know from our COMPASS trial is that when we drew blood on day 1 and then 12 months later, 80% of people had a score that was essentially the same within the margin of error. But that's a question that we're trying to get additional data on of, how long does the score last, essentially.
Thank you.
Okay? Yeah.
Do you know what the gene codes for that you're recognizing?
We have an entire algorithm that I'd be happy to take you through. It's pretty lengthy. We sort of started with about 250,000, and we've whittled our way down to a 23 gene algorithm.
Okay. But do you know what the protein is that it codes for? Is that a clear?
I do not know. You've got a commercial person, but our scientists, I'm sure, would be happy to chat about it. Yes.
In terms of creating awareness for this service, are you going to primary care doctor or are you going to consumer or both?
Yeah, so we've had 10 reps out in the field, and primary care is really the place where there's greater value. Generally once they get to the cardiologist, there's not as great value. As you can imagine, there are lots of primary care physicians out there, so we're just in the process of expanding from 10 to 20 reps, but that still will not get it done. So we are beginning to have some discussions now that we've got some coverage to make sure that we get the message out to patients and thinking carefully about how we best do that. Okay.
Just one, your COMPASS trial,
Yeah.
can you tell us something about it? Was it a multi-dimensional or was it just one group of people? Was it only in the US or all over the world?
It was only in the US. It was about 400 people, and it took a look at patients who were getting ready to go to MPI, and sending them into MPI or doing a Chorus CAD test, and then taking a look at how people progressed through the sort of traditional algorithm versus the Chorus CAD result. Thanks.
There we go. So, hi, I'm Alex Bangs. I'm with Crescendo Bioscience. So I'm going to talk a little bit about a quick background on our company, and then I'm going to kind of take a little step back and talk about personalized medicine a little more generally. The company's in South San Francisco. Locally, our focus is autoimmune diseases, and really we're aimed at working with rheumatologists, starting with rheumatoid arthritis and eventually getting into some of the other disorders they deal with, like lupus, ankylosing.
Can you speak up a little?
Speak up. How about if I get a little closer to the mic? I'm not a yeller, so I just. It's wanting to change by itself. Not too bad. Let's see. Just advance manually. There we go. Okay. A little bit about the challenge of personalized medicine. Actually, for doctors, they've been trying to do this for a very long time. The challenge is the tools that they have available to them are pretty crude in a lot of cases. Drugs are run in very large populations. It's hard to tell what's going to work on an individual when you've got that person in front of you, particularly if the drug only works in 50% of people or less, when you talk about oncology drugs. I just want to relate a personal story of my own. A couple years ago, my mother was diagnosed with gallbladder cancer. That had actually spread beyond the gallbladder. And a couple things about that. It's something that happens, I think, on the order of 4,000 or 5,000 cases a year in the U.S. So and it's actually a very rare disease. And as a result, there are not drugs that are targeted to it. And when it spreads beyond the gallbladder, the prognosis is actually very poor. One of the things, so I went into Google mode and what kind of things can you do, and actually had an opportunity to see a talk by David Agus, who works in oncology and personalized medicine, very interested in this field. And he talked about how cancer in the future really should be treated by the markers, by what the disease activity, not by organs. We're treating this disease by a 150-year-old medical system that's organ-based instead of really by more the physiology of the actual tumor. And he suggested a particular personalized medicine test to use that does a number of expression markers. Not one that's been mentioned today, it was something called Target Now. So we had that done for my mother, and it was interesting to see the physician struggling with not really wanting to order the test, and then when they had the results, not necessarily wanting to use this. And this is a physician at a regional medical center, a physician that had worked inside a pharmaceutical company, was a very technology savvy person. So, we can have all these great tools, but until the physician understands how to use them, that's one part. I think I've appreciated over time that this physician also realized that the prognosis for my mother was actually very poor, and trying to put her through a lot of different therapies was not the right thing to do for a 72-year-old person who, in her view, had lived a pretty good life and was ready to be done. And so, when you look at the things that a physician is trying to take into account, they are trying to look at all the different options and what's going to fit best for a person. If a person's already on treatment, have they started responding? They're trying to predict, what this person is going to do. And in terms of the actual patient characteristics, there are a lot of things, not just the biology, that come into play, including, does this person have a preference about treatment, or, like I mentioned, about end of life, how what they want to do? Are they able to deal with injectables or not? Because if they're not, then their adherence is not going to be very good. And there are financial considerations. So, I think that the talks we had earlier are great examples of, you gave some great examples of things that are negative consequences of doing certain kinds of testing and whatnot, and expense and whatnot, and those are all things that take into consideration. So the other thing is we start to produce more and more things, including, next generation sequencing, the idea of having a whole sequence for everybody. It starts to get a little scary about what do we do with all of that data. And physicians already have a lot to deal with what's kind of on their plate right now. One interesting opportunity to help them would be, instead of you just sort of give them a tidal wave of data right away, would be what's useful for this patient? What's the next test I should do, both from a financial and just other consideration? For each of these tests has some kind of cost to the patient and the system. So there's something maybe we can do in that regard as to what's the right thing to do next. As I mentioned, it's trying to also get physicians to learn the technology and try and fit it into their workflow. Today they may say, my patients are doing fine. Maybe they are, maybe they're not. Getting them to understand that. And then there are, of course, those problematic patients, or their caregivers like me, there was a recent, I don't want to say blog post or a piece about, patients that are Googlers and how painful they can be for a physician. But that's the reality they live in today. So a lot of times when people talk about personalized medicine, if you particularly hear people in the pharma industry, they'll talk about the right drug for the right patient, the right dose at the right time. So there are a lot of things that you can sort of be personalizing. I'm using the word treatment instead of drug because I think there are lifestyle interventions, there are device interventions, there are a lot of different things you can do. And I even mentioned the right diagnostic is another sort of choice to also be made. And I think that can give a great example of that. So there's a lot of wonderful things that we're bringing to bear now in terms of technology on that side of things to help give data to inform that. The other thing is, now that you've made a choice for the patient, does it actually fit the patient, and are they going to start to do useful and interesting things with this drug and actually have it work for them? And there's a lot of interesting data there as well. If any of you are familiar with quantified self, I don't know if Melanie may touch on that a little bit, which is great. But there's a lot of interesting things that people can do, and increasingly tools are becoming available so that you can see, and devices for the home, for example, to see, are people taking their medications? Is somebody's life style continuing, or are they starting to go downhill in some way and need some attention? So I think the opportunity for us is not to just produce these kind of different endpoint solutions, but also to integrate them all together so the patient and physician have a place to see how they're doing and actually have a way to communicate together about that. So let me give you kind of in the area of rheumatoid arthritis, what that looks like a little bit and what we're thinking about. So just RA, give you a quick idea, this is a disease that affects 1.5 million people in the US, 2 million people in Europe. It's a chronic inflammatory disease. It tends to hit predominantly women, and the average diagnosis there is a juvenile version, but it also happens, the adult version is in about people in their 40s tend to get this. It's a chronic condition. It leads a lot of times to disability and sort of significant life impacts for people. So anything we can do to diagnose and treat the disease quickly, part of the idea is to try and get people under control quickly before their joints reach the point of disability and damage to the joints. Now, I could draw a graph very similar to that for diabetes, where the red curve would be glucose, and then the cumulative damage would be all the things that excessive glucose does to your system. The challenge, the opportunity in diabetes, or I should say why it works well in diabetes is because we have great measures of glucose. We actually know what's going on. It turns out in rheumatoid arthritis, until what we brought to market, there hasn't been great ways to do that and to really measure what's going on in a patient. So in a similar way to diabetes, we want to treat early, aggressive. Those are common targets that people talk about in RA. But how do you know a patient is doing well or not? If patients say they're doing well, are they really in remission, or do they still have what they call smoldering disease, where there's actually joint damage going on, but the patient can't feel it? So how can we measure better? So we created a panel. This has been on the market now for almost 2 years now, that gives you a score from 1 to 100 of how active the disease is in the patient. It's based on 12 serum proteins that are measured in our laboratory in South San Francisco. And then we use an algorithm to combine those proteins together. Not a trivial undertaking to do this. It takes a number of years to put something like this together. We did an early screening process with looking at a number of different markers based on literature and database and other areas where we said this protein has an interesting role in this disease. And over time, through a lot of different experimental analysis work, narrowed this down to a set of candidate markers that we went into more deeply into development, and then finally 12 that we put together with an algorithm and then did a validation study to say, yes, indeed, this is predictive of disease activity in patients. And just, let me skip over this, but it's just, the markers play roles in different and interesting areas in the RA to give some diversity of what's going on in patients. So I've talked a little bit about here, kind of on this side, the things that we can bring to bear, more data that potentially can be part of this equation. Another part of the equation for us is what can we do to help the physician understand this data and put it into context. So we've actually created a web-based system for not just getting the most recent diagnostic results, but starting to visualize it with other information. In this case, there's some medication information at the bottom so that they can see, here's the score for a patient over time, how is that changing, and then how is that matched with other interventions that have been done with this patient. More recently, we've created a system where they can actually look at their whole population. And the idea here is having this here on the y-axis, it's people that are in low disease score up to high disease score. But what's really interesting is seeing these patients, for example, that are high disease score and going higher. So the physician can say, oh, I've got some patients that are not really under control and I need to potentially give extra attention to those people. So we're trying to make some tools there for physicians, and we're interested in getting more data over time and exchanging data with physicians to make this even more interesting. Let me flip over to the other side of this, is the patient side. And on that side, we've done a lot of discussions with patients, and one of the areas that's greatest frustration for them, and I think this cuts across a lot of different medical areas, but it's an issue in rheumatology, is a frustration about how well they're communicating with their physician. Are they being heard by their physician? Are they understanding what's going on and why the physician is doing certain things? Are they in agreement about the level of the disease in the patient and what they should do about it? Early research that we're doing with physicians suggests that having this report and having a real objective measure of how the disease activity is helping patients a lot in that regard. But we've done some work more deeply with patients, some design workshops and idea generation with them to say what could we do to help more with this. And that's led us to starting to build actual tools for the patients to use themselves so that they can do some of their own self-tracking of how they're feeling, issues like fatigue and morning stiffness that can be of issues for RA patients. When they come back with their doctor, they can share their information and have a combined discussion at that point. So we're working on affecting all of the different pieces of this, and we think there's a real opportunity to do this not just in RA, but do it more broadly in rheumatology, and obviously something that applies to a lot of other areas as well. As we do this, I think there are some things that apply broadly to personalized medicine in a number of different areas. One is, we do this, we really got to take an approach that thinks about trying to integrate. And it's at the data level. I think in the future, we're looking at things where it's all, all protein measures or gene expression measures, or it's all based on imaging. But we actually need to pull those islands together so that you have a better collection. You have, for example, or sequence information to say the predisposition and the actual blood measures to say now what's actually going on in the patient. Design is really important about this. I think EMRs are a great example of a tool that theoretically should meet all the requirements and is really crappy to use in a lot of cases and doesn't fit the workflow for physicians. So there's a real opportunity, and there are people in that space that are really giving attention to design. But I think that if we want to have effective solutions, we need to pay attention to the context of where it's going to be used. Analytics, I gave you a little snapshot of that so that we help people make sense of the data and try and do more things with the data we print. And the last thing I didn't really touch on, but I just want to mention in a couple different ways, is prediction. So it's something that Crescendo is interested in so that we can go beyond disease activity. We're able right now, for example, to help say this patient is responding well and they've got this patient is responding well or not to a therapy because we can see an early response, say within a week or two, based on some of our pilot studies that suggest that we're able to more quickly show treatment response. But we're looking in the future to be able to develop tests to say, you take this test and we even predict which drug you should be potentially taking as a patient. One of the things that I did in a past life, this is work done several years ago, maybe you've seen David Duncan talk or hear him talk about his experimental man work. It's actually looking at using simulation where you really do integrate all of this data and use it to pick out of a simulated population all the people that look like the virtual David, if you will. And then one of the things we did with that was then make predictions about David's future, in this case heart attack risk, and what effects interventions can have on that. And I'll explain this curve and then I will stop. So what we saw in David was this curve climbing upward said that based on his genetics and environmental factors, that if he gained weight over time, say an average pound a year, kind of creeps up on you over time, that his heart attack risk would greatly escalate. But if he actually kept his weight stable, that it actually stayed down very low. So the other is if his weight increased but he took a statin, we predicted that his risk would be very low. So he had a choice that he could continue to live sort of life as normal and increase his risk. He could manage his weight, or he could go on a statin, and he's chosen to manage his weight. So I think this is an interesting thing. If we start to do this integration, bring more complex modeling to bear, there's some really great things that we'll be able to do to kind of integrate all of these pieces together and do something better for patients and physicians who are helping them.
How's everybody doing? So as we're starting, let me just ask, how many people have their 23andMe data? Handful of people. But has everybody heard of it? That you can order your own DNA online for $300?
And you get a million different SNPs in your own DNA. And on the website, 23andMe talks about how these different SNPs relate to 200 different conditions related to drug response and health risk and so on. Alex also asked how many people are familiar with the Quantified Self movement and meetup group. How many people have attended? So again, more so on the Quantified Self than on the 23andMe genomics. And I'll be discussing more of these in depth. It's a pleasure to be here. Thank you, Rhonda, for inviting me. I'm going to be sharing how our DIY genomics health research studies relate to the topic tonight, personalized medicine and you. Slides are available online at slideshare.net/lablaga. So I would submit that one of the key public health challenges of our era is the realization of personalized preventive medicine. We're tackling the problem in a number of ways, both in the 80% of the condition's life cycle before it goes clinical, and then also once it is clinical. What we've already heard from this evening is solutions in the case of personalized medicine when it's already been recognized, or at least symptomized in patients, such as the personalized molecular diagnostic tests that we've heard about tonight. On the other side, before conditions go clinical, could be a nice time to work on them so that they may not even become clinical. And there are a variety of different solutions in this area already, ranging from the very light touch, say through mobile health apps, of which there are over 7,000, to more intense engagement in activities such as health collaboration communities and crowdsourced health studies. This is the area that I'm more focused in, where we are quite familiar with the social network. We have LinkedIn for business, Facebook for social interactions, and many different kinds of health social networks now, which are online interest communities where members may share information, track their symptoms, and discuss different treatment options. Just as Clay Shirky predicted, not only are these online communities initially about sharing, but they eventually move to more of a collective action kind of activity. And that's been happening now in the form of health collaboration communities, exactly like the Quantified Self, which has 10,000 members worldwide in 80 different meetup groups, and just had its 3rd annual conference at Stanford very recently. My group, DIY Genomics, is also in this collective health space. Our basic research model is towards the goal of preventive medicine. We are conducting predictive risk profiling, determining baseline markers of wellness and their variability, and testing different personalized interventions. In our studies, we're always looking for a minimum of n equals 100 participants. We have 2 independent subject matter advisors on each study who are clinicians or academicians in the area. Our studies are supported by IRBs, and also a new category of reviewer, the citizen ethicist, that is also independent and reviews our study protocols to make sure they pass the smell test. Our generalized research hypothesis is that one or more genetic polymorphisms may be resulting in blood levels or other phenotypic conditions that are already out of bounds, and which may be improved with personalized solutions. This is exactly the format of our first study, which was published in 2010, looking at vitamin B deficiency. In this study, we looked at 2 genetic SNPs in the MTHFR gene, which is related to vitamin B absorption, and then we tested vitamin B and homocysteine levels in the blood. What was most interesting initially was finding out that 75% of our healthy adult cohort was already at higher than recommended levels of homocysteine. And this is related to cardiovascular disease and dementia. What we also found was that personal interventions were very effective at bringing blood levels back into bounds within 2 weeks. And for most people, what worked best was just the regular drugstore vitamin B multivitamin. And for a couple of people, the specialty active form of vitamin B worked better. So what was surprising to study participants was that exactly how effective and quick and a personalized intervention could be, and that n equals 1 in terms of what worked best for the individual, not at all. What works on the average may not work for the individual. So like most sectors of the economy, health is a big data problem these days. And as other talks have mentioned tonight, that we're having more and more different health data streams that are starting to become available and that we need to integrate, aggregate, and look for correlations amongst. Some of these new streams are here on the left in the green, genomics, SNP mutations, structural variation, and epigenetics. The microbiome, the Human Microbiome Project has finished recently. Transcriptome of RNA profiling, metabolome, proteome, the diseaseome, and the environmentome. These new, and I've indicated which are consumer available with a check mark, and therefore that we're able to include in our studies readily. We integrate these with the traditional data streams of health history and standardized instrument response, and then the new kinds of quantified health data streams. And I'd like to mention in particular biosensors as one of the biggest coming areas that people may not realize is on the horizon. That the new platform of wearable electronics is just around the corner. Already in 2007, there were more devices on the internet than humans, and in 2020, there are estimated to be 50 billion internet-connected devices. How many people have ordered a Pebble Watch? Nobody. Well, the smartwatch platform is a very quick emerging platform with products coming out this fall. The basis is the health version of the smartwatch platform, and the Pebble Watch and Wim Labs and Sony Watch, and there are many, many different products in this category. Similarly is a smart ring, also internet connected with information, and wearable disposable patches. Here a picture of the electronic tattoo from MC10 and the $1 API for the bloodstream from Sano Intelligence. Already we are starting to have wearable electronic t-shirts that give us biometric data and dried blood spot lab testing that is much easier than having to go to a licensed phlebotomist to obtain a blood test. In the comfort of your own home, you can prick your finger and measure 20 different items on a regular basis in a much cheaper way on a dried blood spot card. Also, we're already familiar with the continuous glucose monitoring kinds of solutions that are a smaller portable wearable electronic. In addition to the smartwatch, smart ring, and wearable electronics, it's not just about biometric data, but neurometric data. And this is finally a way that we can start to address the brain in a new way, with 24/7 wearable EEG rigs, eye tracking and emotion mapping, and augmented reality glasses like Google Glass coming out also this fall. What's important from a health study perspective is not just the autonomy and agency that everybody will start to have for personal health monitoring and intervention, but also the ability to collect objective metrics on areas where we were previously restricted to self-reported data only. So now moving to some of our specific studies. One of our studies is a memory study that we're operating in collaboration with Armin Schneider, who is one of the world's leading memory experts in Geneva. The study looks at how quickly the brain updates a mental model when physical reality changes. We run this study and all of our studies on the Genamera platform. This is sort of like eBay for health studies, where anybody can post a study and access what is currently a 1,000-member community of individuals who would like to share their genetic data and participate in studies. This is the user interface for the study. It's very clean and user-friendly and indicates that we're looking for a few different genomic variants and what the required tasks are, in this case, completing a memory filtering task and entering some some demographic data. The study currently has 58 data participants and 14 discussion participants, as we realize that we'd like to accommodate different tiers of privacy and participation as individuals feel comfortable. We have a total of 13 studies in open enrollment. I have a handout discussing them all here, and they're all available from our homepage, DIYgenomics.org. Some of our newest studies involve sleep, empathy, the microbiome, and diabetes prevention. In all of the studies, with our modular data stream approach, we're looking at some sort of human genetic SNPs, possibly together with the microbiome sequencing, then some sort of standardized, accepted academic questionnaire, and potentially blood test results. In the case of diabetes, hemoglobin has been recently found to be 10 years predictive of diabetes onset. And so if you have a high risk profile for diabetes and a high hemoglobin level already, then you might really be interested in the intervention. Further, we have additional studies with new collaborations that are in design, dealing with predictive risk profiling in the immune system and the diseaseome, looking at body burden with an environmentome study, and cancer risk and drug response prediction. On the mental performance side, genomics are also very interesting, with some new studies that we're looking at that deal with quantified creativity, learning, and flow state management. These also relate to an interventional platform we're using in our empathy study, where we link genomics with response to a standardized instrument. And unlike any other studies, we actually offer an empathy-building intervention. And we do this with a personal virtual coach that texts you 2 messages a day in a micro-communication format that are designed to improve your empathy. It's open to anybody. And then another, in our diabetes prevention series, we have a planned study linking preference for sweet foods with genomics. So as I look out at the future of Health 2050, the realization of preventive medicine, I see the ecosystem in a much broader way with many more different kinds of players. These could be distilled into 3 tiers, with the individual at the center, and then surrounding the individual, continuous personal informatics health monitoring climate that we get from our biosensors, our neurosensors, and our mobile app platform. This is an ambient information layer that makes suggestions to us in real time regarding our health and well-being and really physical and mental performance optimization capabilities. Then the second tier around ourselves is that of peer collaboration and health advisors. These are new categories of activities where we have our health interest communities online with whom we participate in quantified self-type studies to evaluate different kinds of interventions and track the areas for which we have risk and try to diminish that risk, together with new kinds of job categories like the health and wellness advisor. Third, we rely on the traditional public health system, which has a deep expertise and intelligence in exactly the areas we like for diagnosis and responding to acute and traumatic care. We've been covered in both the mainstream as well as the academic press. And I would like to acknowledge my collaborators and look forward to dialoguing with you about our activities. Thank you.
I'd like to ask the panelists to come up, please. Okay, so I have 3 questions, and then we're gonna open it up to the audience until 8:15, and then Jeff has his demo. So I'm gonna kind of work backwards through the panelists. This notion of genomic literacy. Oh, sorry. The notion of genomic literacy. Melanie, what are some things that we as neoliberals can do to help spread the word?
I think people have a fear about sort of this big data era that we need to know and understand and comprehend all of it. And I think genetic literacy and data literacy more broadly are not a challenge. That what happens is any kind of complicated information is packaged for the different audiences. So in the case of physicians, these are highly intelligent people that have 200 hours of continuing medical education per year. And so now that the FDA has validated genomic testing for 100 different drugs, we're starting to see physicians becoming more educated on what our public health system considers to be the most relevant genomic tests. In regard to individuals, it's just like a blood test. The 23andMe has done a lot in terms of making genomic information consumable. And just like a blood test result shows you the range and whether you're in it or not. So the information can be distilled into consumable, actionable items, and a number of players in the industry are trying to do this.
And what are some of the strategies that you, at companies have employed to drive physician adoption? What are some of the barriers you're seeing, and what are some examples of things you've done to help overcome that?
I can comment that, initially in breast cancer, I think, connecting to the patient groups in particular, breast cancer advocacy is such a big outpouring, so working with the Susan Komans, just a ton of different groups that are out there. So making information available on the web, I think the comments around the Google search and so forth is certainly real. But it's also really getting the education to the physician so that they're in a position ahead of time to be able to respond appropriately and be able to help guide some of the decision making around interpretation, I think, as a result.
Yeah, I would say in primary care, it's a bit of a different challenge, right? I think, specialists potentially have a bit more time and interest in really educating themselves, and as all of us know, primary care physicians have more than their share to do. So it really is about trying to find folks who, have the interest in it and have then the ability to then work this new thing into their office, process, and infrastructure. And finding, while there are an awful lot of primary care physicians out there, finding who those right people are is takes some time and focus.
Yeah, just the one comment I'd also make is that if what you're doing is something that's really new for the physicians, then you may have a two-step process of even needing to educate them why they need what you've got, and then that you have the right product for that need. If you sort of try and skip over the need part and just say, I have this great product that's going to help you do X, but they don't actually believe they need it, it can trip you up. And so I think that's one of the challenges for some of these things is they're really first in class, the first time we've ever been able to measure something, and that requires an extra education process.
So how are some of you dealing with the issue of what Steve Burrell calls perverse incentives? So physicians are basically reimbursed for doing these tests that he talked about. So if they're suddenly not going to be able to do them, but it's going to be a better outcome for the patient, how do you address that?
I'm the first one to say I wish we had the answer. We don't. The reality is that our test is sort of a classic disruptive kind of test when you think about the cardiology arena, because we truly are taking money out of their pockets. That's not to say cardiologists run these tests only for the money. However, there is absolutely a financial incentive for physicians. And so I think we've spent some time focusing on cardiology from an advocacy standpoint, but I think increasingly we're finding that primary care, at least initially, may be a better group to focus on from an advocacy standpoint, particularly as we think about accountable care organizations and the ability to maintain a patient within the primary care physician's care for a longer period of time. So it's a challenge.
Yeah, I can comment, certainly in the area of what we've done in cancer, dealing with a diagnostic for a physician to order it so that then they don't go through and provide chemotherapy treatments, which is really a big source of revenue early on, was a bit of a challenge. In some ways, I'm pleased to report less so than you might suspect, that really, many of the early adopters were really focused on what's the best outcome for patients, and they knew the literature. They knew that they didn't have a way to determine which patient benefited and which ones didn't. And, just to be empathetic to their situation, when they've had a patient that for whatever reason didn't want to have chemotherapy, and then it turns out a year or two later that they chose in support of the patient to not give it, and then they recur with metastatic disease, by which point there is no cure in breast cancer, that really is an indelible kind of memory for an oncologist. So, I think being empathetic to the situation that they face, in addition to being able to then provide the data that they have confidence to make the right decision, because it isn't about really withholding therapy, it's getting therapy to the patients who will benefit and not over-treating those who get minimal to no benefit. But it's always an ongoing discussion on that.
Alex, anything to add to that?
what we do doesn't necessarily rule. I think we're finding right now that just really we're in the business of providing better measurement. And so far, for all the parties involved, patients, physicians, payers, even pharma, they all agree better measurement is a good thing. In some cases, maybe it means that someone would be in remission, maybe eventually we'll be able to take people off of drug for that. But right now, there are a lot of people who don't go on a biologic because they think that maybe, it's got all these risks, but they're not appreciating how severe the disease is for them. So right now, everybody seems to think that more measurement is a good thing, but we'll see longer term if we run into those issues.
And I have, in the vein of innovative cost models and the reticence to pay for anything health-related, a lot of people don't realize that you can actually order your 23andMe data with HSA dollars. So this is a new kind of, over 50% of employers in the U.S. have HSA-type programs, and a number of different kinds of wellness initiatives like 23andMe data, genomic counseling, et cetera, can be paid for with HSA dollars depending on the program. So that's another possibility when you start thinking innovatively about supporting the cost of preventive medicine.
That's great. I'd like to open it up. Right here, please.
Thank you all for a very nice presentation, and for Rhonda and Meetup to organize this. I think I'm showing empathy here too, so that's good. But as a follow-up question, so there is a cost to developing these things. So clinical diagnostics, biomarkers, whatever the timeline may be, whatever the cost may be, less than developing a big pharmaceutical drug and whatever, but there's a cost. So that cost has to be reimbursed in some way. So I can understand from the US healthcare system, but how do you see these applications to the rest of the world?
Good question.
I can comment for in terms of what we're doing. We're working hard to provide access to patients and healthcare systems. I think the challenge is when you start looking at large markets where their total economic system doesn't allow for it, can quickly become something where it's private pay only. With that said, we have invested a lot in markets like Mexico, in which we did several hundred patients studies to be able to provide information to the INCA, the National Cancer Institute, to look at this data. And their focus, of course, is in the invasive node positive market, in which those patients almost always get chemotherapy, and some get even much more kinds of costs and impacts to the healthcare system. So we do a lot of work and studies to help provide it, but it's absolutely a challenge in the majority of markets outside the U.S., in particular around making it accessible, for patients. It's working with the governments, it's providing studies and tests, and collecting the data and showing outcomes, and also showing the impact for so many women who are caregivers, who are missing out time with work and their family. So I think it's an ongoing struggle.
Yeah, I had a comment for the CardioDX. I was wondering that if you can utilize utilization management system already in place by health plans. Many cases when you have to order like radiology test or angiography, it has to go to the pre-auth system, and CareCore or NIA, they already got the system with health plans to give pre-authorization. And once that is in place, primary care physician has no other choice than going through the pre-auth process. Mm-hmm. And if we could make your system as part of the pre-auth to order like nuclear test, then it would just immediately be in place for the primary care. So it's just an idea.
No, I think it's a very interesting idea. We've begun to talk to payers about prior authorization, sort of in a number of different forms, but I think you're absolutely right. That's really where we see the utility of the test, is what we call a gatekeeper to nuclear stress testing. So try this first so that you can rule out a significant number of patients, and working with the health plans to make sure that's the first thing before they go to a nuclear stress test, I think is a great thought.
Yeah, good.
Excellent. Any other questions? Oh, sure.
So I think one concern doctors might have in using new tests is the standard of care, meaning that new tests, but they might be liable to lawsuits because the new test isn't in the standard of care. So do you see that as an issue in getting doctors to adopt new technology?
Absolutely. We do. You know, we hear physicians say, but if I have a picture, then I'm more certain because the picture is what I'm accustomed to. So there's certainly the whole medical legal aspect of uptake of these sorts of tests, and we hear that as pushback. I think, you know, the data that we share with them is some of what I shared with you, the negative predictive value at 96%, and we've demonstrated that in another trial as well. And so, you know, I would expect it takes time, as any standards take time to implement, but absolutely that's a barrier to initial uptake.
You know, one thing I'll just mention on that, which is interesting from my perspective, is early on we thought that that would certainly be an issue where people would withhold treatment based upon the data, and we never really had any legal issues associated with it. What became interesting over the last few years is it's actually reversed, in which, because now we're established in guidelines, there have been cases in which patients receive chemotherapy, have adverse events, and then they were not tested ahead of time to find out whether they would have received any benefit. So I think as society evolves and as we better understand the power of genomics and validated tests, there becomes a question of whether you're doing it too soon or if you're choosing to act and give treatments that aren't providing benefit in patients when there's an opportunity to avoid it.
Great. Okay, thank you very much. Great. All right, Jeff, you're on mission adoption. One thing that Jeff is working on that is very interesting is a clinical decision support tool for physicians so that they can really have the information they need to make the decisions about how to deploy some of these technologies you've heard about tonight at the bedside. So take it away.
Well, after about an hour of hearing talks, I'm going to go fairly quickly. My name is Jeff Showmaker. I have a small company, 21SP. We're developing handheld software tools for physicians to use at the bedside. And hopefully we'll get pharmacogenetics incorporated into general clinical practice. There we go. Yeah, that's a good idea.
Much better. Thank you.
So I'm just going to go quickly through about 4 slides, and then I'll do a demonstration of the software. That's interesting. That's right. There we go. Thank you. Okay, as I said, it's a small company. The software that we've developed is to use pharmacogenetic information to dose warfarin. And basically, the main message to take away from this slide is that many studies have shown that warfarin is effective if you keep the INR level, which is a measurement of how fast a person's blood coagulates. If it's very low, then they're likely to have blood clots, strokes. If it's very high, they're likely to have bleeding. If it's over 3, it's likely to be bleeding in the gastrointestinal tract. If it's over 4, it increases the risk of intracranial hemorrhage bleeding, and roughly 50% of those folks, it's fatal within a month. Basically, what we're all about is, well, let's just go through a quick example. Pharmacogenetics helps to explain how people respond to drug therapy. And atrial fibrillation is a real good example. It increases stroke risk 4 to 5 times. Warfarin has been around for 50 years, and it reduces the risk of stroke by 2/3. So many people in the audience probably know folks, a lot of people in America over 65, 70 take warfarin. My mother's one of them. About 2 million people start warfarin each year. However, during the first 6 months, there's many adverse drug reactions. Roughly up to 25% of people will have a stroke or a myocardial infarction, and up to 20%, 15 to 20% of those people, those 2 million people that start, will have to be hospitalized because of a bleeding event. Most of the time they're not fatal, but they're fatal. Half of them are fatal if they're intracranial hemorrhage. We've developed a tool that's practical and cheap and easy to use to guide physicians, even if they're not experts in pharmacogenetics. We're going to use David Duncan. I think he was supposed to be here tonight. I don't know if he's here, but we're going to use his genetics. He's a popular person for presentations. And basically, he's given me permission to use his genetic characteristics to demonstrate the software. He's very sensitive to warfarin, and his genetics are up on a SNPedia database, a public database. The proper dose for him would be something like 2.5 milligrams a day. The standard starting dose in America is 5 to 10 milligrams a day. It would substantially, and many, many studies have shown this, substantially increase the risk of him having a bleeding event. So finally, a very large study, a very high quality study was published in March this year, and I'll just quote, highly superior to pharmacogenetics-based dosing was highly superior to standard dosing in comparative effectiveness in achieving or maintaining the therapeutic INRs. We saw on the first slide, it's very important to maintain the therapeutic INRs. If you get out of that range, it increases the risk of disability and death. And pharmacogenetics-based dosing basically reduces bleeding events in thromboembolisms, stroke, or myocardial infarction, and it saves lives. It's been proved beyond a doubt. And our tool is very easy to use for general practitioners, even someday probably in the future, nurse practitioners, maybe RNs, who knows. But the idea is to have a tool that steps a physician through the process even though they're not an expert. There's only about 25,000 cardiologists in America, and of course it would be great to have one for everybody, but if you're in Montana or some area in Maine or Appalachia or India or wherever, most of the time you don't have access to a cardiologist. Okay. And we'll just go into a demonstration here. Here's the software. It runs right now on a Samsung Android. It runs very quickly. It goes a little slower now because it's going through a simulation program. And this stuff on the right, you won't see, of course, on the phone. So we'll just pretend that we're using David Duncan's genetics to estimate a dose. And basically, the software it's kind of like a small book. It includes information from published clinical guidelines, published in the CHEST journal. It has drug reference information from FDA-approved drug labels. It has many, many references to pharmacogenetic-based papers and diagnostic test information. So we'll just pretend we're going to start somebody on warfarin. And we'll say initial dosing. And we'll say, Dave Duncan, he's told me he's 54, and he doesn't have any other issues. So the general way that physicians, basically the standard of care right now is that patients will be started out in 5 to 10 milligrams a day for a couple of days, and then they do this INR test. It's a small blood test. As I said, it measures how fast blood coagulates. And the target for atrial fibrillation, at least, we'll pretend he has atrial fibrillation, is usually 2 to 3 unless somebody has a heart valve. But in 2009, we can see at the bottom of the screen, New England Journal study paper co-authored by a couple of professors at Stanford that I reviewed this system with, came out and said that for roughly half patients, the standard way of doing it, or traditional trial and error method of doing it, is not accurate, and you can do much, much better, and I'll show you how. So we'll back up, we'll go back to don't have to go that far back. We'll go back to the main screen, we'll just go down to pharmacogenetics. And there's two ways to do this. This is the algorithm that's been tested in something like 5,000 patients. If we're a standard person, we can't see. Anyway, we'll pretend initially that Dave Duncan doesn't have any gene variants, and we'll just say he's 1 here, we'll say he's 1 here. Basically a standard person. He is 54, he told me. Whoop. Gotcha, thank you. And I have a little trouble seeing the keyboard. There we go. Thank you so much. That's great. And he's 6 feet tall. And for our purposes, he's 6'0". This calculates the body surface area, which is important in cancer therapy, but also in some heart disease. And he says he's 190 pounds. He does not take, this is an antiarrhythmic drug. He doesn't smoke. He does not have deep vein thrombosis or pulmonary embolism. We'll say his target INR is 2.5. There we go. Thank you so much. Great. It's much easier. And he is not of African origin. So the dose would be roughly 7.2 milligrams a day. You can see the average, the sort of standard starting dose, I don't know if it's proper to say average, but the standard starting dose in the United States is 5 to 10 milligrams, so it's 7.2 milligrams. Very small difference. So let's just back up and quickly go through him with his true genetic characteristics. And he is a TT for, whoop, here we go. He is very sensitive on the drug target, so he has to have a much reduced dose. He doesn't have this particular variant. He's intermediate in the CYP2 C9 variant. He's still 54. He's still 6 feet tall. He's still 6'0". He's still 190. He doesn't take any additional drugs that would influence this. He doesn't smoke. He doesn't have that. 2.5. Not African origin. And so, does anybody want to guess what his dose would be? It's very sensitive. Okay. There it is, 2.5. So David Duncan, and it's impossible to tell. It doesn't matter, it's just impossible to tell. One person in the room could need 1 milligram per day to have the proper dose to maintain that INR range of 2.5. Another person sitting beside you could need 20 milligrams a day to maintain the INR of 2.5. So nobody can tell. You need to do a pharmacogenetics dose based for warfarin. Warfarin's a life-saving drug. It's a cheap drug. It's like $300 a year compared to the newer drugs that are like $3,000 a year. It just is a very tricky drug to use, and one of the goals of my project is to help educate physicians out in the clinic that this is something that's very easy to do. Currently, the test is only being done. There was a recent, I've seen the data on this several times. A recent study said that about 4% in Minnesota, some people did an analysis of data from Blue Cross, Blue Shield, and some pharmacology benefits organization. And so they think about 4% of people are being tested, 4% of the 2 million people if you extrapolate it out to the United States population. So maybe 4% of the 2 million people are being tested before prescribing the dose. And the test, the average cost of the test now is about $150. And turnaround times are 1 day, maybe 2 days. And probably at some point in the future, people are talking about a matter of hours. So it's a very simple thing to do, but it's very important for the patient. So with that, I'll just say, I'm not sure how much time we have. I think I might have used up all the time, but does anybody have any questions?
I have one. How do you factor in drug interactions? You know, Coumadin is notorious for multiple drug interactions? Will somebody take
The
the
physician,
liver?
yeah, there's actually, there's a whole list of interactions in the system. The system will guide the physician. It's just in a different area than what I showed you just because of lack of time. There's 110 different screens on this. It's intended to be an expert system that will guide anybody with some medical knowledge in understanding how to dose the drug properly. If somebody has to go into surgery, you know, when do you stop? Do you stop 5 days before surgery to give the person vitamin K, which is an antidote to warfarin, and it lists the drugs that basically would alert the physician to the fact that there's a whole list of drugs that would make warfarin, would enhance warfarin's effect, to make it more likely that somebody would bleed. There's also a whole list of drugs that retard warfarin's effect, make it more likely that there would be blood clots and strokes. So it's in there. We're glad to show you after the break.
So the prerequisite is to have the gene expressions for the patient? I mean, what is the
Yeah,
minimum?
you have to have a genetic test done. And on average, at least in Minnesota, it's about $150. Some companies will turn it around. Kimball Genetics in Denver will turn it around in the video when they turn around. In a big study at the University of Utah recently, I'm not sure, what precisely how they did it, but they had to turn around in just a few hours to test. So on the drug label, it says if you don't know genetic information on the FDA-approved drug label, if you don't know genetic information, start a person out at 2.5 to 5 milligrams a day. And so then you might have the test the next day and these will correct it.
How many medications do you have in your kit?
Right, this is our first product. And it's not on the market yet. It will probably be in the market in the next 2 weeks to 4 weeks, in October sometime. This is just working. Okay. But we're planning on using this model for a whole range of medical decision making.
How will the pharmacy provide these customized doses? Like, let's say the person needs 1.2 milligrams as opposed to what you start out
If
as.
it's 1.2 milligrams, I don't know what the person does. They'll just have to, the physician will have to recommend the dose.
Get it 2.5 and cut it in half.
And that's how it's done now. I mean, they break it, at least one person on the warfarin told me, break it in 4 pieces type thing. So it's not 100% precise, but it's still way more precise than is traditionally done.
Jeff is going to be around to answer the remaining questions. Looks like there's a bunch. So thank you all for coming tonight. And
Thank you very much.